we will explain to you. You all are familiar with the Italian Job, no? There's an awesome movie which had come in about an Italian heist. And as we research on hysteroscopy, most of the hysteroscopists are Italians, whether it is Luca Mencaglia, Tinelli, Spinelli, Bighetti, and of course now it is Bertocci. So one over the other, they have improvised on the hysteroscopic techniques, and so they are getting better and better at it because they have a lineage and a hierarchy to develop from. Some of the visionary hysteroscopy innovators, there are so many of them: Bozzini, Nietzsche, Pantaleoni, Hamu, Rubin. Stefano Bertocci is now the person who has revolutionized hysteroscopy for us. So what will we discuss today? The man, the machine, the ergonomics, the maintenance, and a little bit of the future. What about the man? Who is a hysteroscopist? Yes, a lot of observation, a lot of training, a lot of supervised procedures are important. You have all that knowledge which requires to be there. But then what is most important is, in a world inhabited by patients wanting a hysterectomy, the hysteroscopist must possess exceptional counseling skills, and believe me, that's what I do most of the time, converting a hysterectomy into a hysteroscopy, and it is no mean deal. So we talk of the machine, which have the optics, you have the fluid distension systems, the mechanical systems, and the electrosurgical unit. So we need a good camera which is a good resolution for sharp images. High sensitivity means with lesser light it gives very good images. A digital signal processing for clear and sharp images. You need an autoclavable camera head, user-friendly controls. What is important is it is compatible with several hysteroscopes and light sources, good recording capacities, a less signal to noise ratio, and a good video output quality. There are so many in the market. As far as light sources are concerned, so what is important is, there are two types. One is an LED light source and the other one is a xenon light source. An LED light source is less expensive, it has a longer lifespan, it gives a lower heat output, very energy efficient. But a xenon light source has got a high brightness, consistent light distribution, it is expensive and can generate more heat. So what I do is, in the OPD I use LED light scope, and in the OT what is used is a xenon light scope. A monitor of a good size, preferably more than 27 inches, necessary cables and connectors. Data archiving is important because we need to explain to this patient, to the next patient, and for medico-legal purposes. A light cable is again of two types. You have a fiber optic and a liquid crystal. A fiber optic is flexible, bendable, but little fragile and most commonly used. Liquid crystals are more durable, but they are a little less flexible. What is important is you need a 180 centimeter length, a 2.5 to 5 millimeter diameter. Normally the 5 millimeter gives more light. Many times you get a 2.5, a 3 and odd dimensions. Now into the world of hysteroscopy, let us pay homage to Harold Horace Hopkins, because he dramatically enhanced the image definition, and he it's not turning. It's going to take a while. I have a few short clips. I think that I'm worried if I take it on a USB, will it play? I'll end up doing nothing if something is wrong. Okay. So, yes, where were we? We have finished about the camera. We have done the light sources, monitors, cables, and we have finished the light cables, and we are giving a tribute to Harold Horace Hopkins, because of whom we have the telescopes. So the standard 4mm 4 oblique scope is what I started with, and now that is relegated to only operative hysteroscopy. Bertocci's hysteroscope is now dominating the system, in which every office procedure and most of the operative procedures are done with this scope. So what about the Bertocci scope? They are very tiny scopes, 1.9 mm, 2.9 mm. It has an oval tip. If you are able to see this, it helps to negotiate very well. Integrated sheath in which you can put in 5 French instrument. It has an inside sheath and outside sheath. You can sometimes work just with the inside sheath alone if the ostium is, if the cervical internal os is very narrow. And the movie is not opening because I am not in the movie will open only, I think, in my laptop. So, thank you. So, I just wanted to show you how we negotiate with the small scope, in the office setting itself. What are the advantages? There's a reduced patient discomfort. You can see and immediately treat in the office. There is a good visualization because it is continuous. Earlier on, when we had a diagnostic sheath, there was no outflow channel. Now in this, we have an inside and an outflow channel, which is very important because it washes away all the blood and debris. So it gives us a very good vision. You can use a variety of mechanical instruments through this. Again, I am handicapped because I am not able to show the movies. I just want you to show, okay, we have a Caesar, we have a forceps, we have an alligator's grasper, we have tenaculums. Then we have a bipolar needle, we have a monopolar needle. Again, I am handicapped because I am not able to show the usage. There is a high frequency Versa point generator. You can keep adding on to your paraphernalia. But what is important is having a good Bertocci system, a good resectoscope, a good underwater bipolar generator, and everything can be covered. Yes, you have a fancy money, yes, you can add up with a Versa point, which is a good bipolar high frequency generator, which again works with, you can vaporize tissue, you can do it for septums in a simple way without much dilatation. Now, what about the resectoscopes? You have a narrow resectoscope is something which is used to do the operative part. It is an electrosurgical instrument, and you have a resectoscope starting from an 18 French to a 26 French. Of late, most of us are using an 18 and 22 French. We relegate the 26 French for large fibroids or large lesions. Why? Because it is faster. It has a wider loop, so it can take out a large volume of fibroid easily. While an 18 French or a 22 French is enough for small lesions. You don't have to dilate so much. In fact, you don't have to dilate at all sometimes with the 18 French. What else do you have? You have a unipolar and a bipolar system. You have an active or a passive type. And what does a typical resectoscope contain? It contains a working element, which is the most important. The working element is what defines whether it is a unipolar, a bipolar, an active, or a passive system. You have an inner sheath which is actually insulated, an outer sheath which is corrugated to allow the fluid exchange. Now I have a beautiful movie which I can't show you to differentiate between an active and a passive. Active resectoscope is normally used by urologists. It is very fast. While it is fast, but then the loop remains outside. While for a passive resectoscope, we put out the loop and we bring in the loop. It is more under our control, a little slower. You need to be mentally oriented to which resectoscope you are using, because if you are using the passive and somebody hands over the active, and suddenly instead of pulling it in, you push it out and you could perforate the uterus. You need to know this difference, and the working element is the most important part of the resectoscope. An electrosurgical generator comes as a monopolar underwater or a bipolar underwater. In a monopolar, it is widely used because it can be, most of them have got systems which can be used for laparoscopy. They have a bipolar system which can be used for various other laparoscopic work, open work. So it is cheaper. It is more versatile. It delivers higher power and it is less expensive. But what is the problem? From the electrosurgical unit to the active electrode, to the tissue, to the return electrode, to the unit. This is a wider arc, so where you can have burns. Plus, you have to use non-electrolyte media. When you use glycine, there is definitely a higher chance for fluid overload, which is the most dreaded complication of hysteroscopy, as my further speakers are going to speak about. In case of a bipolar underwater, this is a dedicated bipolar underwater generator, which is, you have to ask specifically for it. Reduced risk of complications like burns and fluid overload. It is more expensive. But if you see from the generator to the active blade, to the patient tissue, to the passive blade and to the generator. So it's a very small arc, less complications, and now it is a preferred system. What about the media? A media, it's a collapsed cavity. To distend the cavity, you need something inside. So that is how the media does. What does the media do? It allows the complete visualization. It allows unnecessary contact of the instruments with the uterine wall because there is a media intervening. There are two classes. You have a gaseous and a liquid. Gaseous is now outdated. I won't speak about the carbon dioxide. It was early on used for diagnostic hysteroscopy. Nobody uses it anymore. Liquid, again, you have a high molecular weight, low molecular weight. I won't talk of the high molecular weight HISCON because it is not used anymore. Let us talk of the low molecular weight distension media. In this, you have a non-electrolyte and an electrolyte. Non-electrolyte is used for monopolar underwater hysteroscopy. What is the commonly used? Glycine. Of course, sorbitol, mannitol is there. I have not seen it being used, but it is glycine which we use. And in case of bipolar underwater system, the commonly used is 0.9% normal saline solution. It is very cost effective and we have to use it. If you have an underwater bipolar, you have to use a normal saline. How do you distend the uterus? So you have one thing is traditionally for many years there is a bag, pressure bag which is commonly used. It is kept at a height and you can squeeze it. Okay, but what is the problem? The problem with it is you cannot actually moderate the pressure inside the uterine cavity. So you could end up pushing more, you could have fluid overload. Okay, but in case of these dedicated microprocessor controlled irrigation suction pumps, what I use is the Shocky system. So stores and many others have come up with this. So in this case you can set an intrauterine pressure, though it is not very accurate, but you can set your flow rate. You can keep an irrigation pressure of around 70. I operate normally with a 70 to 80. You can increase it depending on the resistance, the poor vision we find inside the uterine cavity. So when you use a low intrauterine pressure, the distension medium doesn't go from the uterine cavity through the tubes to the peritoneal cavity. That is one advantage. It reduces the risk of vasovagal symptom and pain. And very important, if you are doing an office hysteroscopy, you cannot work without this. You cannot use a distension bag for an office hysteroscopy because it's a very sensitive environment. We cannot have pain, So when you avoid the pain, the only way to avoid the pain is minimal distension. Morcellator is a newer addition. It is mechanical, it aspirates, cuts, but it is very easy to learn, especially for beginners. Yes, you can easily train with a morcellator. You can do office procedures with a morcellator. Yes, but what is the catch? The catch is it does not coagulate the bleeding vessels. So when you are operating on a very vascular or a large fibroid, you can get limited because there is so much bleeding. Then you have to keep increasing the distension. It can get messy. I have not worked with a morcellator because I belong to a very simple setup with less paisa. I mean, they don't give me whatever equipment I need because it depends on the number of numbers. The number game, I'm not into the number game, so I will get only the basic instrument. I'm very happy with my resectoscope. Now, what about the ergonomics? This is me. What is the ergonomics? What I do is, you need to have a patient table which can go up and down. You need to have a chair which can go up and down. What I do is, I keep the equipment on the right side. All the cables come from one side, left side. There is no crossing of cables. So you have the 3-liter bag here, you have the distension system here. The eye, this is of course a little higher, but if you can have an eye level, it is very nice because you don't have to keep doing this. You cannot see like this. It's always easier to see like that. So I insist that the camera is on the left side. You have the electrosurgical unit also on the left side. So all cables on one side and I take my instruments myself. My assistant stands on the left side, helping me with the speculum if required. And the most important thing is the fluid monitoring. If you ask me the essence, the crux of hysteroscopy, it is fluid monitoring. What is a big deal? You are cutting something. But what is important? The patient doesn't get into trouble. How? It's only by fluid monitoring. So I have the hysterojet here, the 3-liter saline suspended here. I have the foot pedal very close to my left leg. The outflow goes into a suction bottle which is placed in a bigger jar. And there is a constant monitoring. Every liter of fluid which comes out is monitored as to how much comes, how much has gone in, how much has come out. The anesthetist is informed and a deficit is monitored liter by liter. So staff training is extremely important. So what do I have in my office hysteroscopic car? दुनिया भर का slide बता के फायदा नहीं है. What I am doing, if I explain to you, I share my experience with you. So in an office hysteroscopy, all that is required is hand instruments, the 5 French instruments. That is, you have a 2 scissor, one scissor is spare, one alligator forceps. You have the Bertocci system. That is, I have a 2.9 mm scope, an inner sheath and outer sheath, which completely comes out to about 4 millimeters. This is sufficient. But sometimes, supposing the patient doesn't cooperate, supposing I am not able to, get in, I keep this as a spare, a speculum, a valcellum and a sound, so that I grab it, because we all do copper T with grabbing, no? So I think I give the patient that, let me grab it and put the scope inside. But that's a rare phenomenon. So what I tell the patient is, if I'm able to see, I charge you. If I don't see, I don't charge you. You only pay for the saline or for something. In an operative hysteroscope, what do you need specially? What is my most important thing is half centimeter graded dilators. You can have a single end half centimeter, double end half centimeter. We are dilating a gynec uterus. It is not good to have an open cervix because all the water will come gushing in, you can't see anything. You need to grade and dilate. So this is my most important equipment there. Of course, I have a speculum, a valsalum, a sound. I have a small ovum forceps, a small sponge holder to grab some of the tissues which don't come out. I have a 4 mm scope. This is the operative hysteroscope, which is normally a passive, which I use along with the cables. Along with the loops. Now, this is my team of Satish Reddy, Rajita and Radha. Very, very grateful to them because the fluid monitoring, if Satish is there, I'm not worried about the fluid. My team anesthesia, Dr. Meera, Venkat and Ashok, they have supported me in every way because I feel hysteroscopy, operative hysteroscopy is the anesthetist's job and the team person's job. I do nothing, I'm just doing a resection, which is no big deal actually. So maintenance is very important. What matters is they're very fine instruments. There is blood, tissue, which has to be immediately cleaned. You have to manually clean, disengage everything, put it under a running water jet so that every blood spot is removed because that can go rust and your instrument doesn't work. Rinse it well. Normally I use 2% glutaraldehyde, which is actually Sidex. You can have autoclavable, you can have gas sterilization, but this is what I'm very comfortable with. And what is the future? Perhaps assure hysteroscopic tubal occlusion could come back to fashion. Robotic hysteroscopy is again something, perhaps what they say is that simultaneous use of instrument and the camera independently. Now we have everything integrated. Perhaps that could be the change, a better vision perhaps. Hysteroscopy in reproductive technology, gamete intrafallopian transfer, embryo transfer, something should come in for that. Improved diagnosis and treatment of receptivity, so better successful implantation using the hysteroscope. Second generation endometrial ablation. Thank you. Thank you very much. I really apologize because I had some cute clips to show you what is an active, what is a passive, but I was not able to. Thank you very much for a patient hearing. Just खींच दो.